Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about palliative care with Dr. Dmitry Kozhevnikov. Dr. Kozhevnikov is an assistant professor and associate program director of the Yale Hospice and Palliative Medicine Fellowship at the Yale School of Medicine. Here's Dr. Weiner.
So maybe we can start off, as I often do, hearing a little bit about you and your background.
So I was actually born in the Soviet Union, and when I was a year old, my family escaped ethnic conflict that was going on in the Caucasus region to the U.S., and we settled in New York City, where I spent most of my childhood. And my mother was actually, and still is, an emergency room nurse, and so I was exposed to healthcare and medicine at an early age. And when I was old enough, I actually signed up to be a volunteer in the ER, and I trained myself to be an EMT.
And can I just ask, was she a nurse in the Soviet Union and then retrained here?
No, she went to school here.
She went to school here?
Yeah,
okay.
They were very young when we came, and she worked really hard to achieve that goal, and was definitely a huge inspiration for me, not only to go into medicine, but overall as a human being. And so I ended up being on this path to become an ER physician. But then as I progressed through my medical training, I realized that it wasn't really the setting that I wanted to practice in. What was more rewarding to me was developing these long-term relationships with patients and being able to spend time with them and learning about them and giving them care that was more sort of humanistic and, person-centered, and really had the time to figure out what's important to them and how to best care for them. But I was also influenced by a lot of the patients that I cared for earlier on in my career, who taught me that medicine is a lot more than just giving patients the most recent and newest treatments. It's really about making sure that they feel heard and listened to and understood as well. So this power of presence is something that I learned early on, and I continue to do it as I practice today. And then I learned also that patients who are facing serious illnesses like cancer, they want to feel as well as they can for as long as they can. And so I knew that doing extra training after my internal medicine residency in hospice and palliative medicine was one of the best ways to gain the skills that I needed to help them do that. And then lastly, as part of my story, I followed the love of my life, my wife, to Connecticut for her training in pediatrics when I matched to Yale fellowship here. And I've been fortunate to be here for 7 years. And like you mentioned, most of my time is spent seeing patients in our clinic. But when I'm not doing that, I'm either teaching other clinicians how to communicate effectively with their patients, and I'm also training our fellows as an associate program director. So I've been really fortunate with these opportunities.
Well, I think one cannot overstate the importance of good communication between clinicians of all sorts, doctors, nurses, social workers, what have you, and patients and their families. And it's that partnership that's really so very critical and which I think you really help to enhance. Let's just go right to what people always think and dispel some myths. So people hear words like hospice and they think things like, my doctor's given up on me, I'm just going someplace, or I'm going on some program that's at the very end of my life. And while there are certain situations where that seems to be the case, it's really not using palliative care and hospice to its best advantage at all. So help educate our listeners.
Of course. So in taking a step back, we know that there are about 13 million adults in the U.S. with a serious illness. And patients with the serious illness often have needs that are, unique and require a tailored approach and extra support in different areas, like not only the physical experience, but their psychosocial experience, spiritual, and there's other areas that we focus on. But palliative medicine, the way I think about it, is a subspecialized medical care for patients with a serious illness that is provided by high-functioning teams, like ones that are composed of physicians, nurses, nurse practitioners, chaplains, social workers, psychologists, pharmacists. So multiple people of different training and backgrounds that all come together and try to figure out where extra support can be added to the patients. And the beautiful thing about palliative care is that it can be provided to patients at any age and any stage of an illness, from diagnosis to later on. And people do not lose anything by receiving palliative care, because it's just an extra layer of support on top of what for example, their oncologist is doing for them. So hospice is a type of palliative care that's only provided, like you mentioned, to patients who are thought to be in sort of the last 6 months of their lives.
But not necessarily the last week of their lives either.
Absolutely, yeah. And, what we've found is that patients who enroll in hospice sooner get more time to benefit from the support and the services and actually have better quality of life. So we try to encourage that whenever we're seeing a situation where a patient may not want further treatment because it doesn't fit their goals, or they aren't, unfortunately, a candidate for any more treatment. We try to get them as much support as we can at that moment. And hospice is one way to do that.
And palliative care, as you've mentioned, goes way beyond hospice. And palliative care is really focused on maximizing patient comfort, not just physical comfort, as you've already pointed out, along the way. I've often been struck by the fact that, if someone's resistant to palliative care, that on some level they're indicating that they are comfortable not being comfortable. And of course, many oncologists are fairly skilled at providing appropriate palliative care, but having a dedicated team member like you can often be very helpful.
Yeah, we are so appreciative of when we're involved. And I think one of the examples that comes to mind when I try to help people figure out the difference and realize the difference between the two fields, hospice and palliative care, is by sharing a brief patient story without any details, but just to give people an idea of what it might look like. So one of my patients has metastatic breast cancer, and she's been seeing us for 5 years already. So we've been very involved in her care from diagnosis. And she's actually a patient of Dr. Samt, who I know you've had on the program recently, who's a very respected colleague of mine. And it's really nice to be able to collaborate with her. And one of the things we help this patient and other patients is with cancer-related pain, nausea, other symptoms, while she's going through different treatments that might be changed at different points in time. And so, for her, we see her every 3 months. We check in on how she's doing physically, emotionally, and we celebrate the good things with her. So, for example, she went on a cruise recently. Was really excited that she was able to do that because she was feeling well enough to travel and spend that time. And it was really rewarding to know that, we played a role in sort of making that happen.
And in much the same way that cancer treatment, the drugs we use to treat cancers, have become ever so much more complicated over time. Approaches to pain control, approaches to the management of other symptoms have also become more complicated. And it's pretty hard for any one individual to keep all of this in their head. When I'll just use another example, patients will occasionally ask for a medicine for depression or for some other emotional, psychological problem. And my response is usually, I can give you something, but I'm not the expert in this area.
That's right. Yeah. And I have expertise as well, but I draw more on my team members, like my social worker. We have a psychologist. So I think the beauty of our field is that we accept the fact that we know a certain degree of things about depression or pain or anxiety or nausea, but we draw on each other to really fill in the gaps. And I think talk therapy is really something that helps a lot of folks. And support groups is another area where some of our patients come back to us and say, it's amazing to really be in a group of people who understand and know what I'm going through. Even though there are plenty of people around me that kind of are aware of it, it's a totally different thing to be really talking about it with folks kind of in a similar situation.
Now, of course, when we get other doctors involved in caring for our patients, one of the key issues is sometimes communication among us. How do you approach that, and how do you think about that? Because, of course, there's always the potential when you have 2 and 3 and 4 doctors taking care of one patient that there are mixed messages and some miscommunication.
That's such an important point. And what we know is that when we communicate better and more smoothly without the patient there, I think when we talk to patients, we actually have a more uniform and a message that is the same from different people, which is so important, because one of the things I hear that's so frustrating, and I can imagine this as well, is hearing one thing from one doctor and then another thing from another nurse. And so we really emphasize working together closely and supporting each other, because a lot of these experiences we have in medicine as clinicians can be really challenging and sort of lead us to feel like, how can we provide empathy when we're going through such difficult times ourselves? But I think as we support each other, that's another benefit of having such an interdisciplinary team. We can provide better care and more a consistent message and communication to the patients too.
I haven't done this to the best of my recollection working with a palliative care doctor, but oftentimes when patients are referred in by other oncologists, in the presence of the patient, I will use my cell phone and call the oncologist and put that person on speakerphone so that we're all communicating together. And I found that to be very useful in much the same way that I would imagine that for you, communicating together is often really a way of avoiding a lot of challenges.
I love that idea, Eric. And, that's something I could probably do more often. But what's worked for a lot of my colleagues and myself is also, even if it's just messaging before and after appointments, because everyone's so busy. But when I have that opportunity, I always jump on it, because patients want to know that the people that they trust, their oncologist, their primary care doctor in many circumstances, are involved and agree with what's going on. So we definitely try to incorporate everyone.
Well, we're going to have to take a break in about a minute, but let me just ask you one question before the break, which is, how old is palliative care in the world of cancer? When did this all start, and when do you feel that it really picked up in terms of getting traction among the oncology community?
That's a good one to answer in 45 seconds, but I think I could do it. So palliative care as an idea has been around since the 60s, 1950s and 60s, when folks around the world, but I think primarily in the UK, recognized that patients who were dying of cancer had very poorly controlled symptoms and were very little support. And so there was this movement over there abroad to build that support, and it turned into the hospice movement in the 1970s and 80s, with Connecticut Hospice in Branford being the first one in the United States. What happened really then was this growth from hospice of the palliative care movement, recognizing that patients way earlier than the end of their lives need the support as well while they're going through the treatment, and that could be for many years. So that was a huge gap that I think grew in the early 2000s, and with our specialty being recognized actually in 2008. So it hasn't been too long with that official recognition, but the ideas have been around for a while.
An old problem, but a field maybe not in its infancy, but certainly not beyond adolescence. All right. We will take a brief break, and we'll be back with you in just a minute.
Support for Yale Cancer Answers comes from Smilo Cancer Hospital, where their thyroid care ablation program offers an alternative, non-surgical approach to treating symptomatic or aesthetically unappealing thyroid nodules. SmiloCancerHospital.org. The American Cancer Society estimates that more than 65,000 Americans will be diagnosed with head and neck cancer this year, making up about 4% of all cancers diagnosed. When detected early, however, head and neck cancers are easily treated and highly curable. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilo Cancer Hospital, to test innovative new treatments for head and neck cancers. Yale Cancer Center was recently awarded grants from the National Institutes of Health to fund the Yale Head and Neck Cancer Specialized Program of Research Excellence, or SPORE, to address critical barriers to treatment of head and neck squamous cell carcinoma due to resistance to immune, DNA-damaging, and targeted therapy. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
This is Eric Weiner with Yale Cancer Answers. I'm joined tonight by our guest, Dr. Dmitry Kozhevnikov, who is an assistant professor at Yale School of Medicine in the Department of Medicine, and is a palliative care expert directing our ambulatory palliative care program. Let's get back to the discussion about palliative care and when palliative care. So when do you think that, and I realize there's no single answer to this, but when do you think it's the right time to introduce the concept of palliative care to a patient with cancer? It's probably not something you're going to introduce to a woman with very early stage breast cancer who's having a lumpectomy and radiation and going on a pill to prevent a recurrence. But what are the situations where you think about this?
Yeah, I think about this a lot. And, one of the challenges that we face is that there is a shortage of palliative care experts in the country. For example, for every 100,000 patients or citizens or, folks in the country, there are 8 cardiologists and 5 oncologists, but only 2 palliative care physicians. So this kind of illustrates the challenges that we are juggling when we're thinking about who to get involved with and how early. Technically, we can get involved in patients' care at diagnosis, but what I've found in working with oncologists and some of the research that's happened over the past few years kind of is trying to find that sweet spot of, it seems to be more when patients have some sort of unmet need. And that could be, again, physical with cancer-related pain. That could be symptoms that are related to their treatments. And those are the patients that I think benefit the most and come back to us. It can't hurt to explain what palliative care is to any patient with cancer, but getting them to come to another appointment can often be challenging with so many other appointments. So it's sort of weighing the benefits and the burdens of that as well.
And do you feel like, in these last 20 years that the field has changed a great deal?
I do, yeah. I think 20 years ago, the focus was more on building inpatient palliative care teams. So teams that are seeing patients while they're in the hospital, admitted with some sort of acute issue. And that has really been a huge area of growth to the point where now, 90% of all hospitals in the country have at least some sort of palliative care team. And what's happening now is the realization that why don't we provide these services sooner before patients get sick while they're stable and going through treatment in the outpatient setting. And so the growth of ambulatory or outpatient palliative care teams has picked up over the last few years as patients and families and clinicians and hospital systems realize the benefits of involving us sooner.
And is inpatient palliative care or institutions like Connecticut Hospice that, initially had dozens and dozens of patients there who were, living the end of their life in a facility, has that remained the same way, or is there more of a push to get people home?
I think that most people want to be at home. There are certainly cases that are really challenging to treat at home, whether that's because of symptoms or limited support. But about 95 or 96% of patients on hospice in the country are at home or outside of the hospital. And there is a push, really, I would say, to align the treatment that we're giving to patients and the families with what their goals are within limits, obviously. And there are cases that we're involved with that are very complex, and maybe the patient wants to be at home, but they're not able to for various reasons. So we try to find a middle ground and work with them. But it used to be that inpatient hospice units were accepting patients who might not be towards the end of their lives or not have symptoms that could be managed somewhere else. But now, with Medicare regulations being what they are, there's really an emphasis on making sure that patients who are in the inpatient hospice unit or hospital with hospice services require that level of care, just because that is sort of our system. And I wish it wasn't, but that's sort of where we are. And I think the point that I want to leave listeners with is that the goal of palliative care teams is really to make sure that patients are being heard and aligning their values and hopes with whatever the other doctors that we work with are offering and doing for the patient.
Yeah, no, I think that's really, really very critical. So what are the kinds of services that you're able to offer in the outpatient setting?
Sure. Our team is fantastic. I can't speak enough about them, but usually when patients come to us, they have a medical visit first with either a physician or an APRN. And at that point is when we evaluate whether or not there are unmet symptoms or needs. And those could be things like I mentioned earlier, physical or psychosocial. Sometimes they're financial, sometimes they're spiritual. So we work very closely with our social workers to see whether there are either resources that aren't being tapped into, grants or other financial things that can be looked at. But also how people are coping. How are they doing with this new diagnosis? Because everybody's different, but this is a heavy thing to deal with. So we look at it from different perspectives. And if someone does say, hey, I would really benefit from talking to someone about this, we can offer them visits with our psychologist or even our social worker, checking in with them periodically. And we tailor it to whatever their needs are. There are some patients who meet us who really are doing well, and we check in maybe every 6 months or a year, and then if things change, we can change the frequency of visits. So it's really a personalized experience.
It is dramatic how different people cope so differently and react so differently to a diagnosis of cancer or really any other diagnosis. And I think the trap you can fall into as a clinician is to expect people to behave a certain way, and you really have to be open to all the surprises. So let's talk about some people who often don't get talked about, and that is the family members. Because as we talk more about hospice at home, this often puts a pretty significant burden on the family members in the home and some outside of the home, and it's not always family. Sometimes it's friends.
Yeah, this is, I can only imagine what it's like to have this role of being a caregiver for a family member at this time of their lives. It's obviously an honor and a privilege for most people, but it's such a hard thing to do with everything that's going on in their own lives. So as much as we can't fix everything, what we can do is look at each situation and try to guide folks on what makes sense for them, whether that is getting family members mobilized and sort of taking shifts and turns, taking care of their loved one, or it's private paying for an aide a few hours a week, or looking at the situation kind of from a bird's eye view. And because sometimes we're so narrow focused, even myself, that we kind of forget that's a really important thing to look at. And supporting our caregivers is one of our priorities as a team as well, because we know that without the caregiver being so involved, the patients are not as well taken care of. So I think that every day when we see patients, we're always looking out for how are you doing? I know you're taking such good care of your mother, but let's take a minute and breathe. And are you eating? Are you sleeping? What's going on in your life too?
And this can often go on for an extended period of time. I mean, there are people who live very active lives until very close to the very end. But there are others, particularly people who may be older or may have more in the way of other illnesses, who just are really incapacitated for a longer period of time. And it is a huge burden for the family members. And, the other issue, of course, is that some family members are just more medically savvy than others.
Mm-hmm. That's right.
So there is a big piece of education. Do you see a role for support groups for family members?
Definitely, yeah. I know that our system, and Smilo in particular, does have caregiver support groups available. So I would ask about that for any caregivers. And there are also plenty of online resources that I've kind of been surprised to learn about. I mean, you wouldn't think about it, but Facebook is a good place to find, patients with multiple myeloma or breast cancer, or caregivers of patients with those diseases. And there are other websites that I can't think of off the top of my head, but there are certainly other resources that we try to help patients find, and they often find them on themselves, on their own as well.
Now, I'm struck again about communication. And when we talk about patients and families, sometimes there isn't perfect communication between the two. And that's often about the family member protecting the patient and the patient protecting the family member. Just wondering your thoughts on that and how you and your team deal with that challenge.
Yeah, I think we recognize that patients and their caregivers and their loved ones and their social structure around them are often very well established, and we don't try to change that to a degree, unless it's unsafe for any reason. But most families have some sort of tension points or disagreements and challenges. So our role is really not to be the fixers there, but to help within that context to try to help them as they face this serious illness, and sometimes be the sort of the mediator between conflicting people or teams. And that's an area where I think it can be very meaningful, because there might be a barrier that there's a conflict that's preventing a patient from getting the right treatment or from getting the right care at home, and trying to listen to both sides and figure out a solution is really important.
Well, I think that one of the things we see, and I'm going to now paraphrase from Tolstoy's Anna Karenina, that all happy families are alike and all unhappy families are unhappy in their unique way. I think that families that function really well together do better in these hospice situations, and those where there's a lot of conflict have trouble.
Of course, yeah. I really appreciate your Tolstoy reference.
It seemed appropriate.
Definitely, yeah. And, one of the hardest things that we see, and you probably see this a lot too, is where patients don't have, maybe they're estranged from family and they don't really have much support. And our system is just designed in a way it's poor, because it relies a lot on, and it assumes that everybody has a good amount of support at home. But there are so many patients that we try to help that don't have that, often to no fault of their own. And so trying to help navigate the system for them and help them through that can be really hard on patient and the teams that we help, and also us.
Dr. Dmitry Kozhevnikov is an assistant professor and associate program director of the Yale Hospice and Palliative Medicine Fellowship at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilo Cancer Hospital.